Consequentialism is an umbrella term for any of the moral theories that state that the rightness or wrongness, goodness, or badness of an action is solely dependent on the results the action produces. The most famous version of consequentialism is utilitarianism. Consequentialism, the doctrine that the moral rightness of an act is determined solely by the goodness of the act's consequences. Prominent consequentialists include J.S. Mill, Moore, and Sidgwick hold that an act is morally right if and only if it produces the best consequences of those acts available to the agent. Satisficing consequentialism holds that an act is morally right if and only if it produces enough good consequences on balance. Consequentialism is the more abstract version and extension of 19th-century utilitarianism, the idea that the ultimate value is pleasure or happiness, and that pain and suffering are the ultimate ills to be minimized or avoided. An action is ethically right if it has desired consequences. Consequentialism often requires calculation about the likely outcomes of actions and their effects on a sentient being. In modern times, Peter Singer, in Practical Ethics, has perhaps been the most influential of those offering a more sophisticated utilitarian defense of the value of animals. Singer's approach, as a version of consequentialism, evaluates consequences in terms of the extent to which they satisfy the preferences of the agent's granted moral consider the ability. A few versions of consequentialism are agent-relative, that is, they give each agent different aims, so that different agents' aims may conflict. For instance, egoistic consequentialism holds that the moral rightness of an act for an agent depends solely on the goodness of its consequences for him or her. Unit 2. Medical Ethics. Medical ethics is an applied branch of ethics which analyzes the practice of clinical medicine and related scientific research. Medical ethics is based on a set of values that professionals can refer to in the case of any confusion or conflict. These values include the respect for autonomy, non-maleficence, beneficence, and justice. Such tenets may allow doctors, care providers, and families to create a treatment plan and work towards the same common goal. It is important to note that these four values are not ranked in order of importance or relevance and that they all encompass values pertaining to medical ethics. However, a conflict may arise leading to the need for hierarchy in an ethical system, such that some moral elements overrule others with the purpose of applying the best moral judgment to a difficult medical situation. Medical ethics is particularly relevant in decisions regarding involuntary treatment and involuntary commitment. As this field continues to develop and change throughout history, the focus remains on fair, balanced, and moral thinking across all cultural and religious backgrounds around the world. The field of medical ethics encompasses both practical application in clinical settings and scholarly work in philosophy, history, and sociology. Medical ethics encompasses beneficence, autonomy, and justice as they relate to conflicts such as euthanasia, patient confidentiality, informed consent, and conflicts of interest in healthcare. In addition, medical ethics and culture are interconnected as different cultures implement ethical values differently, sometimes placing more emphasis on family values and downplaying the importance of autonomy. This leads to an increasing need for culturally sensitive physicians and ethical committees in hospitals and other healthcare settings. The term medical ethics first dates back to 1803, when English author and physician Thomas Percival published a document describing the requirements and expectations of medical professionals within medical facilities. The Code of Ethics was then adapted in 1847, relying heavily on Percival's words. The practice of medical ethics is widely accepted and practiced throughout the world. Medical ethics was once concerned with the professional obligations of physicians, spelled out in codes of conduct such as the ancient Hippocratic Oath and elaborated by contemporary professional societies. Today this subject is a broad, loosely defined collection of issues of morality and justice in health, healthcare and related fields. The term, bioethics, is often used interchangeably, though it is also used with its original broad meaning, which included issues in ecology. The range of concerns grouped under medical ethics begins with the relationship of doctor to patient, including such issues as consent to treatment, truth-telling, paternalism, confidentiality and the duty to treat. Particular moral uncertainty is engendered by contexts which demand divided allegiances of physicians, such as medical experimentation on human subjects, public health emergencies and for-profit medicine. Issues in medical ethics arise in every stage of life, from the fate of defective newborns to the withholding of life-sustaining therapies from the very old. Medical practices with patients who may not be competent to make their own medical decisions, including pediatrics and psychiatry, raise a distinctive set of ethical issues, as does medical genetics, which involves choices affecting family members, future individuals and offspring in utero. In recent years, medical ethics has broadened its focus beyond the individual physician or nurse to include the organization, operation and financing of the healthcare system as a whole, including difficult theoretical and practical uncertainties regarding the fair allocation of healthcare resources. Confidentiality. Traditionally, medical ethics has viewed the duty of confidentiality as a relatively non-negotiable tenet of medical practice. Confidentiality is an important issue in primary care ethics, where physicians care for many patients from the same family and community, and where third parties often request information from the considerable medical database typically gathered in primary health care. Confidentiality is commonly applied to conversations between doctors and patients. This concept is commonly known as patient-physician privilege. Legal protections prevent physicians from revealing their discussions with patients, even under oath in court. Medical confidentiality is a concept of doctors maintaining all the information received during the course of the patient's treatment. It involves a set of rules or a promise usually executed through confidentiality agreements that limits access or places restrictions on certain types of information. The patients on a daily basis share their secret or sensitive personal information to the health care providers such as doctors, physicians, hospitals, etc. If at any point, the patient feels that the information is not protected and there are chances that it may get divulged, then they might not share the information in the first place. Therefore, it should be at the topmost priorities of the health care providers to maintain the privacy and confidentiality. The patient's confidentiality regarding his/her treatment is of vital importance and should be protected. It is the right of an individual that his/her personal and medical information is kept private or confidential. Such delicate and confidential information about the individual should only be in between him and the doctor, physician, healthcare or health insurance company. The medical information of the patient given to a healthcare provider shall not be divulged to others unless the patient gives his consent to disclose such information to others. The confidentiality of a patient should be maintained because the communication of personal information or records may create personal or professional problems while the patients depend on doctors to keep their medical information private. Though it is very rare to keep the medical records or information completely undisclosed, as a very common breach of confidentiality occurs when the doctors pass the medical information to others and refer it as one of their case studies. If this information gets published in professional journals, the identity of the patient is never disclosed, and if it appears in any way, then the patient has the right to use. Apart from the publishing of the case studies, one more threat or risk to the medical privacy is the fact that most of the medical bills are paid by the health insurance company, so in that case, it is very difficult to keep the information secret, as health records can be viewed by insurance companies as well as by the medical laboratories, researchers, etc. It is necessary to keep a privacy applies to a person. Privacy means keeping the medical records restricted or in the vault from the public release because it protects the patient's identity. If in any case, such personal medical information reaches the unauthorized third party and the identity of a patient is ascertained or known without the consent of the patient, then such patient can take legal action. Whereas, confidentiality applies to the data. It refers to an individual's right to have personal and detectable medical information which remains private between the patient and the physician. It is an extension of privacy. Confidentiality of the patient is an essential element of the personal regard for the patient and also an essential criterion to uplift an honest and transparent conversation between patient and physicians. Divulged information about the patient's treatment is important as it helps the doctor understand the case thoroughly and properly. There are so many rights which the patient has and can duly exercise them whenever they require. Some of the rights are: right to appropriate medical care and humane treatment, right to information, the right to choose healthcare provider and facility, right to medical records, right to privacy and confidentiality, etc. So, the right to privacy and confidentiality is one of the rights given to the patient, where the patient has the right to be free from public exposure, but are subject to certain exceptions, which are, like, 1. If the mental or physical condition is in question and the court orders the patient to surrender himself to a physical and mental examination by a physician, or 2. When the public health and safety demands, or 3. When the patient himself gives up his right in writing, or 4. It can be disclosed to the parents or the legal guardian of the patient where the patient is not of legal age or mentally incapacitated, and if the patient is of legal age, then the information can be disclosed with his right to choose the person to whom the medical information should be communicated. Patients routinely share personal information with healthcare providers. If the confidentiality of this information were not protected, trust in the physician-patient relationship would be diminished. Patients would be less likely to share sensitive information, which could negatively impact their care. Creating a trusting environment by respecting patient privacy encourages the patient to seek care and to be as honest as possible during the course of a health care visit. It may also increase the patient's willingness to seek care. For conditions that might be stigmatizing, such as reproductive, sexual, public health, and psychiatric health concerns, confidentiality assures that private information will not be disclosed to family or employers without their consent. The obligation of confidentiality prohibits the healthcare provider from disclosing information about the patient's case to others without permission and encourages the providers and healthcare systems to take precautions to ensure that only authorized access occurs. Appropriate care often requires that information about patients be discussed among members of a healthcare team. All team members have authorized access to confidential information about the patients they care for and assume the duty of protecting that information from others who do not have access. Electronic medical records can pose challenges to confidentiality. While there may be cases where the physician feels naturally inclined to share information, such as responding to an inquiring spouse, the requirements for making an exception to confidentiality may not be met. If there is not explicit permission from the patient to share information with family member, it is generally not ethically justifiable to do so. Except in cases where the spouse is at specific risk of harm directly related to the diagnosis, it remains the patient's, and sometimes local public health offices rather than the physician's, obligation to inform the spouse. Truth-telling. Truth-telling or honesty is seen as a basic moral principle, rule, or value. Withholding information or otherwise deceiving the patient would seem to at least disrespect patient autonomy and potentially harm the patient. Respecting patient autonomy means allowing patients to make their own decisions about whether to have certain tests, procedures, treatments, or other interventions recommended by the healthcare provider. It means allowing patients to be in control of the course of their lives to the extent possible. The physician may tell the patient only what he thinks the patient wants or needs to know, leaving out technical details and other irrelevant details that would have no bearing on the patient assessing risk and decide about the procedure. This might be seen as withholding information, if it is recognized that anything less than telling absolutely everything possible is this kind of innocuous withholding. But on this view, the physician must not withhold any significant information and must not deceive the patient. On this view, then, the physician would have to truthfully disclose the diagnosis to the patient rather than trying to cover it up, lie about it, or minimize the severity. The physician would not be morally allowed to be unduly optimistic about the likelihood of success of possible therapeutic interventions either. The physician is not allowed to give false hope. This view certainly clashes with the older, paternalistic view of physician authority that would sanction lying to the patient about terminal cancer. The issue of truth-telling in bioethics is closely related to that of informed consent, as it involves weighing paternalistic concerns against the autonomy interests of patients. For genuinely good reasons, out of a concern for promoting health and preventing harm, a physician may wonder whether it is always best to tell the complete truth to patients. And, as in the case of informed consent, the justification for a requirement of truth-telling is based largely on protecting the patient's autonomy. During the first day, we will discuss the issue of truth-telling largely as it applies to delivering complete, and often bad, news to a patient. On the second day, we will then turn towards the more specific problem of medical error, which is related to truth-telling and its concern for what patients ought to be able to say to their patients. In particular, then, we will focus on medical error and apology. When physicians communicate with patients, being honest is an important way to foster trust and show respect for the patient. Patients place a great deal of trust in their physician, and may feel that trust is misplaced if they discover or perceive lack of honesty and candor by the physician. In addition to fostering trust and demonstrating respect, giving patients truthful information helps them to become informed participants in important health care decision. Thus, patients should be told all relevant aspects of their illness, including the nature of the illness itself, expected outcomes with a reasonable range of treatment alternatives, risks and benefits of treatment, and other information deemed relevant to that patient's personal values and needs. Treatment alternatives that are not medically indicated or appropriate need not be revealed. Facts that are not important to the patient's ability to be an informed participant in decision-making, such as results of specific lab tests, need not be told to the patient. Also, complete and truthful disclosure need not be brutal. Appropriate sensitivity to the patient's ability to digest complicated or bad news is important. There are two main situations in which it is justified to withhold the truth from a patient. As noted above, if the physicians have compelling evidence that disclosure will cause real and predictable harm, truthful disclosure may be withheld. Examples might include disclosure that would make a depressed patient actively suicidal. This judgment, often referred to as the therapeutic privilege, is important but also subject to abuse. Hence it is important to invoke this only in those instances when the harm seems very likely, not merely hypothetical. The second circumstance is if the patient states an informed preference not to be told the truth. For instance, some patients might ask that the physician instead consult family members. In these cases, it is critical that the patient give thought to the implications of abdicating their role in decision-making. If they chose to make an informed decision not to be informed, however, this preference should be respected. One of the most predisposed values to being truthful is associated with respect for the patient as a person who is able to make decision. This is because, to determine a course of action and governance of care for a patient, the patient requires nothing less than truthful information. The provision of truthful information to patients is one way to enable them to make correct decisions which benefit their overall health. Without knowledge of the truth, it would be uncertain whether patients can make informed decisions and would lead to failure of health professionals to respect them as autonomous individuals. Lying is held to be a breach of the autonomy of the person, and this contradicts concepts such as patient empowerment, shared decision-making and patient-centered care. This is essentially significant to a health professional obtaining informed consent, whereby the potential risks involved in the proposed treatment and intervention need to be disclosed truthfully. To consent to any health intervention, a person requires sufficient and truthful information to make an informed and conscious choice. Arguably, patients cannot make effective decisions without truthful information. The second value is on duty and trust, whereby Kant, one of the leading Western philosophers, believed that everyone has a strict duty to tell the truth even if it might be harmful. He believed that lying could never be an excuse, as it was always harmful to a particular person or to mankind in general. If harm results from telling the truth in a compassionate manner, then it is an accident, but if harm results from a lie, then the liar is responsible. Kant further supposes that telling the truth is always a duty, whether it relates to the other's right to know or results in innocent people being severely harmed. In other words, from a deontological point of view, competent patients should be told the truth regardless of the consequences. It can also be argued that, given the value of trust in any health professional-patient relationship, then such trust must be properly facilitated and fostered throughout patient care. This may not be possible if patients discover that they have been deceived by health professionals who are otherwise trusted to not tell lies. Furthermore, while lying may be justified at times, its main effect soon becomes evident, that despite liars believing their actions to be benign and in good faith, those deceived may feel upset and wary. The third value is the physical and psychological benefits of telling the truth. One of which is the positive benefits on the patient. Those who are well informed tend to collaborate with health professionals and seek to be treated. This is based on the belief that once the patient knows their diagnosis and prognosis, they can tolerate the treatment and the pain more positively. Meanwhile, in the absence of disclosure, harm may result from not seeking treatment. We must not forget that telling rather than withholding information will allow a patient to plan their care, seek other opinions and put personal and financial affairs in order. Therefore, it is very difficult to think of a situation where lying can ever be acceptable in the therapeutic relationship. Moreover, honesty also helps protect the patient from overtreatment, which is neither kind nor beneficial. There is some evidence to support the notion that informing patients the full truth about a life-threatening disease does not result in a greater incidence of anxiety, despair, sadness, depression, insomnia or fear. In fact, informed patients engage in better communication with health professionals, resulting in greater trust in the care provided. Furthermore, it is alleged that not informing patients of the natural course of their illnesses deprives them of what is called a good death. If, for example, patients were made more miserable by being given information about their condition and risk of alternative treatment, if it is what the patients wish to know, then health professionals are morally obliged to tell them the truth. Beneficence. The term beneficence refers to actions that promote the well-being of others. Beneficence is defined as an act of charity, mercy, and kindness with a strong connotation of doing good to others including moral obligation. In the medical context, this means taking actions that serve the best interests of patients and their families. However, uncertainty surrounds the precise definition of which practices do in fact help patients. The principle of beneficence is the obligation of physician to act for the benefit of the patient and supports a number of moral rules to protect and defend the right of others, prevent harm, remove conditions that will cause harm, help persons with disabilities, and rescue persons in danger. It is worth emphasizing that, in distinction to non-maleficence, the language here is one of positive requirements. The principle calls for not just avoiding harm, but also to benefit patients and to promote their welfare. While physician's beneficence conforms to moral rules, and is altruistic, it is also true that in many instances it can be considered a payback for the debt to society for education often subsidized by governments, ranks and privileges, and to the patients themselves learning and research. To act beneficently toward others is to behave in such a way as to do good, on behalf of, or to benefit, someone other than oneself. To the extent to which healthcare professionals serve their patients by helping them to maintain or improve their health status, healthcare professionals can be said, to the same extent, to be acting beneficently toward the patients they serve. In theory, every action performed by a healthcare professional, in a professional relationship with a patient, can be expected to be guided by the ethical principle of beneficence. Moreover, the respect for patient autonomy and the practice of beneficent medical care can be considered to be mutually complementary. 4. It is difficult to imagine a healthcare professional who is committed to the principle of beneficence, on behalf of one's patients, without also respecting the right to autonomous decision-making on the part of those same patients. However, despite the complementary nature of the ethical principle of autonomy and that of beneficence, it is not uncommon for these two ethical principles to conflict one with the other. It is possible for a patient's autonomous preference to appear to conflict with what is in that same patient's own best interests. For example, a young adult patient who has only recently suffered a ruptured appendix, such that it is still early in the progression of pain, might refuse to undergo an appendectomy for the reasons that the patient has never undergone surgery before and claims to be deathly afraid of hospitals. To respect this patient's autonomy is for the patient to, inevitably, die, which, reasonably, is not in the patient's own best interest. On the other hand, to coerce this patient into agreeing to the appendectomy, and thereby to prevent the patient's death, would be to fail to respect the patient's autonomous preference. It is also possible for a patient's autonomous preference to appear to conflict with the best interests of someone else. For example, a patient who has only recently been diagnosed with a serious sexually transmitted infection, STI, might agree to treatment for this STI only on the condition that the healthcare professional in question promise to refrain from telling the patient's spouse about the STI, as the patient's attempt to invoke the privilege of confidentiality that is considered to be inherent in the healthcare professional-patient relationship. To respect this patient's autonomy is to place at risk the health status of the patient's spouse, at the very least, regardless of whether the patient is provided treatment for this STI. Such cases of conflict between these two ethical principles would normally be adjudicated according to which right, that is, that of autonomy or that of beneficence, can reasonably, and objectively, be determined to supersede the other in importance. In the former example, the patient, after recovering from the life-saving appendectomy, might be appreciative of the fact that the principle of beneficence was allowed to prevail over the principle of autonomy. In the latter example, the right to know, on the part of the patient's spouse, of one's own potential health risks involved in the patient's having contracted the serious STI in question would allow for the principle of beneficence concerning another rather than the patient to take precedence over the principle of autonomy. Of course, many are the occasions on which the principle of respect for autonomy might take precedence over the principle of beneficence. Take, for example, a patient who is similar to the one in the above-mentioned case of a ruptured appendix in that the patient is, once again, deathly afraid of hospitals, but this time is elderly and has had only one surgery, although a major one. This time the surgery is recommended to remedy a leaky mitral valve in the patient's heart. If, having had a series of bouts of patient education such that the cardiologist can, reasonably, determine that the patient is sufficiently aware of the ramifications of both options, that is, the likelihood that the mitral valve repair would be successful and the equal likelihood that refraining from undergoing this mitral valve repair would, within a relatively short period of time, result in the patient's death, then respect for this patient's autonomous decision to refrain from undergoing this surgical procedure might reasonably be seen as superseding this patient's right to beneficence, that is, to actually undergo this surgical procedure. Dr.